Hi guys, my name is Lily, and today I'm going to be talking to you guys about parental nutrition along with Brian and Caleb. For the sake of this video, we're going to call it PN for short. So what is PN? PN is going to be the administration of nutrition via the vein, so intravenous nutrition, and then it's going to give patients all of the nutrients, vitamins, and minerals that they would normally have if they would be able to digest and absorb macronutrients. So the macronutrients are delivered to the patients in their simplest forms, such as carbohydrates, proteins, fat, vitamins, and minerals. So there's two different types of PN. There's central parenteral nutrition and peripheral parenteral nutrition. The difference in these types of nutritions is the type of administration and where they're going to be administered on the patient. So PN is going to be supplied through an intravenous catheter, just like this one showing here. And then so for, if we go back the slide, central parenteral nutrition, the IV catheter is going to be in the supravena cava, and then for peripheral parenteral nutrition, it's going to be located somewhere in the peripheral veins, along like the extremity of the arm. So then PN is going to be given to a patient in a balanced PN formula. So, and then it's going to be infused through continuous or cyclic infusion. PN does require proper care from the hospital staff, so it is important for the staff to be checking the infections, be checking if the blood glucose levels go up too high because it's not good for the veins. They could just potentially blow. And then they should check electrolyte levels just in case the patient needs like an IV run of like a certain vitamin or like phosphate or something. And then fluid issues or metabolic issues as well. So why is a patient administered PN? So it's going to be because they're unable to use their GI tract to digest or absorb food to get like the nutrients and the macronutrients that are needed. So qualifications for PN are going to include intensive care units, so critically ill patients, small bowel obstruction, malnutrition, GI fistulas, and then it's like 7 to 10 days after the patient was admitted to the ICU, and if EN is not feasible. Patients who have failed EN, severe short bowel syndrome, and severe acute pancreatitis. And then so PN can be given to a patient ranging from like infants to adults. It's shown that like in sick premature newborns, PN is going to give, it's a little bit better to be given to them because it's going to provide them with a better level of nutrition versus any other type of feedings. It's because like PN provides a mixture of like vitamins, nutrients, fluids, minerals, electrolytes, so versus other feedings where they would just be receiving sugar and salt, so it helps them out a little more. And then PN can be administered on a patient for a very long time, so it could even be like an at-home administration, and then for a short amount of time, so like just at the hospital until they're able to like start PN and they get better and they're qualified for like EN or even oral nutrition. So when it comes to critical illness, the body goes through metabolic changes. These are going to include protein catabolism, increases, BMR increases up to 40%, relative insulin resistant state occurs. Malnutrition in critically ill patients is associated with impaired immune function, muscle weakness, increased ventilator dependent days in intensive care, length of stays. So it also decreases morbidity and mortality, and the degree of cumulative energy deficit has been shown to be directly proportional to the number of complications that they experience. So basically, PN can help delay the metabolic changes in the body, so it's important to be administering PN at the right time, which is something that Caleb is going to touch upon later.
Hi guys, my name is Brian Felix, and Lily touched upon why a patient will qualify for PN, and I'm going to just expand on that and talk about why a patient would not qualify for EN, otherwise known as the contraindications. So what is EN? EN, as described in Aspen, is nutrition provided through the gastrointestinal tract via a tube catheter or stoma that delivers nutrients distal to the oral cavity. And so these are the different ways that EN can be administered. It can be administered through the nasogastric tube, which travels down to the stomach and and it goes into the nasoduodenal tube to the nasojejunal tube. It can also be surgically inserted through the gastrotomy tube or a jejunostomy tube. So these are the contraindications that I'm going to be going through with you guys. So one of the contraindications is non-operative mechanical GI obstruction. So if food is obstructing the GI tract, enteral nutrition would not be the most optimal nutritional intervention that would be administered to critically ill patients. Another contraindication is intractable vomiting or diarrhea that is refractory to medical management. So if someone has persistent nausea, vomiting, or diarrhea, the most optimal care that would be administered is to try and get the diarrhea and vomiting under control. So another contraindication is severe short bowel syndrome, and so one of the criteria used is if the bowel is less than 100 centimeters, and also if they have a malabsorption disorder. So if they have a non-functional small intestine, EN would not be the most optimal nutritional intervention, just because EN is administered through the GI tract. So if the small intestine is not working properly, the patient would not be able to absorb any of the nutrients that would be administered. So criteria that we would use to diagnose this are malnutrition, dehydration, and weight loss caused by diarrhea. And so another contraindication would be paralytic ileus. So that basically means that the small intestine isn't undergoing peristalsis. So one way to differentiate the diagnosis between an ileus and a mechanical obstruction would be an ileus would have symptoms such as steady pain and gas through the bowel, and mechanical obstruction would have colicky pain and gas cutoff. And another contraindication is a distal high output fistula. So fistula is described as a gastrointestinal fistula is an abdominal opening in your digestive tract that allows gastric fluids to seep through the lining of your stomach or intestines. And so this is an image that kind of shows what it kind of looks like. And so the problem with this is when this happens, the fluids start to leak subcutaneously under the skin, and so this can increase the rate of infection. And another contraindication would be severe GI malabsorption. So as I described earlier, EN is administered through the GI tract. So if the small intestine isn't working properly, the patient isn't going to receive any nutrients. And another contraindication is severe GI bleeding. And so this is often caused by peptic ulcers. And again, this would just increase the rate of infection. And the last contraindication I'm going to talk to you guys about is the inability to gain access to the GI tract. So, like I described earlier, EN is administered through the GI tract. So if you're not able to have access to the GI tract, this would not be the most optimal way to provide nutritional intervention. And so that's all I have for you guys as far as contraindication goes for enteral nutrition. And now Caleb is going to talk to you about some of the evidence that provides why parenteral nutrition is and isn't the best means of nutritional intervention.
Hi guys, my name is Caleb Yankovic, and today I'm going to be talking to you a little bit more about why patients should receive parenteral nutrition. So just kind of to brush back up on what Lily talked about early on in the video. So parenteral nutrition indication, so why are we going to give them parenteral nutrition? If they failed enteral nutrition, they have severe short bowel syndrome, a mesenteric ischemia, small bowel syndrome, GI fistula, malnourishment, or a high risk of, or a high nutrition risk. So I'm going to kind of be focusing on the last one, the malnourishment and the high nutrition risk factor. So when to initiate parenteral nutrition? So there's different standards. Aspen is one that we use here in the United States, and then ESPN is what they use in Europe. So there's 2 different routes you can go. So Aspen recommends initiation of PN at 7 to 10 days in a healthy patient. Now this is a healthy patient, not a patient that is malnourished, but critically ill, but not malnourished. So that's what we're talking about here. Espen recommends initiation of PN at 2 to 3 days in a healthy patient. So the study was done by the University of Pittsburgh to kind of determine which one is more effective and which one works best. The study did find that the late initiation actually is a better route to go with, and it showed the late initiation group had an increase of 6.3% in the likelihood of being discharged early. So, and the median stay for the late PN initiation was 1 day shorter. So what this kind of means is if you can hold off on PN as long as possible, it's probably the best route because it is a pretty intensive form of nutrition therapy, and it does come with a lot of risk involved with it. So now we're going to talk about when to initiate in malnourished and at-risk patients. So this is kind of more what we're going to talk about today. So Aspen recommends initiation of parenteral nutrition immediately in malnourished or at risk of malnourishment critically ill patients. So this means when a patient comes in malnourished, critically ill, you want to get that PN started immediately upon arrival to the ICU, if in is not possible, of course. So there's always going to be different situations that come with this, and there is a huge risk associated with parenteral nutrition from infection, complications, blood sugar going up. So there's a risk-benefit ratio, and you want to kind of weigh that out. And each case is going to be different, but a patient that is malnourished already, you really want to get that PN started early on. So why do we start in malnourished patients? So an analysis was done on the use of PN in malnourished ICU patients, and it showed that it significantly lowered their complication rate in these patients when they started early on in these malnourished patients. And also the early initiation of PN nutrition was also associated with a lower rate of infection in these patients. So get it going early on these malnourished patients, they're usually going to have a better outcome. Now the study compared standard methods of feeding with PN nutrition and which one had a lower morbidity rate as well. And there wasn't really a big difference in that area, but they did find a really big difference in the rate of infection and complications. So parenteral nutrition in malnourished patients. So this is kind of what the bread and butter of what we're talking about here. So immediate PN is really important in these malnourished patients due to the catabolic state they're in. So they come in, their bodies are already in a catabolic state, they're already breaking down, their bodies are breaking down, so it's really crucial to get that nutrition in them as quickly as possible. This starvation or malnourishment can have deleterious effects on the immune system and major organ dysfunction. So your immune system is going to start shutting down, your organs are going to start shutting down because there's no nutrition in your body. So this patient comes into ICU, critically ill and malnourished, you got to get that PN started as soon as possible. There's also going to be metabolic changes and stress in these critically ill patients, which can lead to significant protein catabolism resulting in muscle wasting. So your muscles are going to start wasting, your body's going to start breaking itself down for any form of energy it can find. So that's really not what you want. You don't want to have muscle wasting. It comes with a bunch more complications, so as soon as possible, once again. And malnourishment in critically ill patients can limit wound healing. So if you have a patient that can't get EN, critically ill and malnourished, let's say a burn victim or something like that, they have to have something to rebuild their body tissues, fix those wounds. So it's really crucial that they get some nutrition in them quickly to get that started again, to get the wounds healing going. And then malnourishment in critically ill patients is also associated with prolonged hospital stays, increased death rates, and higher costs. So it's really crucial to try to get them out of that malnourished state as soon as you can with that PN. So here's some questions we got for you guys. Lily here is going to ask you guys, why is PN a last resort for nutrition administration in critically ill patients? Brian here says, when is it an optimal time to begin switching a patient from PN to EN nutritional therapy? And then I got this one for you guys. Why does initiation of PN in malnourished, critically ill, or critically wounded patients help promote wound healing? So that's once again kind of talking about like the burn victim or some situation like that. So thank you guys so much for watching our video, and we look forward to your responses.